We'll just get started. We're probably a little bit ahead of time. I just wanted to also say, just highlight that this session is going to be recorded because we had quite a lot of interest from people who are going to be on annual leave this week because we're smack bang in the middle of the school holidays. But they wish to review this. So for anybody else that would be interested, there will be a recording available and circulated either at a later date, which you can also forward on to any colleagues that might be interested in watching it. Yeah, as Connie's already said in the slides, by default, cameras and mics will be disabled because it can affect the bandwidth and the quality of the connection as well. So I suppose without further ado, I'd like to introduce Grant Brand and Dr. Anna Fletcher, who are going to take us through their presentation.
Hi folks, good afternoon. Thanks for the invitation along. If just next slide please, Connie. So it's just basically we've got fairly short time here, so trying to keep this as concise as we possibly can. This is the makeup of the Glasgow ARBD team, so designed basically so we can basically meet a range of needs across the health and social care, and these are the disciplines that we require for our assessment process. Next slide. I think one of the important things to kind of stress is, as I've said here, the accessibility of the service. We don't want to be we don't want it to be a service that's knocking back referrals, or one of the things that really winds me up is getting letters. This would be more suitable for such and such a team, and it's clear that that's never been discussed with us. So we have an open referral, and if we're not accepting a referral, then we can hopefully offer advice and support and maybe redirect, or try and get some kind of outcome for somebody. We'll take referrals by phone or letter or email. We used to say back in the day we wanted a provisional diagnosis, and that is helpful, but since we need to reevaluate for rehab potential anyway, we quite often have to carry out differential diagnosis. In the event that there's kind of anything that we feel is worth discussion, or we need more information, we can discuss things with people on Teams. And it's a full MDT sort of perspective on all the referrals we receive. I suppose that kind of fits from day one when we're getting we're getting a referral, getting information, or hearing about a case. We're already starting our own process of differential. Next slide, please. Now, I sat down with the referral form a couple of years ago and looked at it, and we had like a 5 or 6 page referral form. And it suddenly occurred to me, we don't actually need that amount of information. This is what on the left-hand side here is what the referral form now looks like. We've got a version for acute, for community services, and for GPs. And the major difference is the acute form. We're wanting to know what's been happening during this admission, as opposed to the history you would get from acute. We realise also now that if we just basically got the demographics, we've got access to clinical portal, we've got access to EMIS, we've got access to Care First 6. We have all the information that we require, including scans, etc. So we just keep it short. Just get enough information, review all the availables, and see if we're think the information we gather at that stage is pointing us towards alcohol-related brain damage. And we could move to the next slide now, please. It's probably important as well that you have when a working definition for your service, and this is what we've come up with: impairment to brain structure and function, which is seen to be secondary to a history of excessive alcohol consumption and associated nutritional deficiency, non-progressive and abstinence from alcohol. I think what we're trying to have there is kind of a definition that's kind of friendly. We're not trying to be too restrictive in what we're saying, but we are trying to also be clear that we're not talking about progressive conditions, and we're not talking about injury to the brain which has been caused when someone has been intoxicated, etc. That does come up. So I think that's quite a friendly definition. I think it's quite clear, what we're looking for. I think nowadays that, it's the alcohol consumption and thiamine deficiency, and particularly the thiamine deficiency, that's kind of recognised as the big player in the sort of in alcohol-related brain damage. Next slide, please. So once we've got a referral in, first things we kind of do is, when we all disciplines in the team take part, try and gather as much information as we can, and particularly going to relatives and carers, etc. To try and get their history. What do you know? What's happened? Have there been any changes? It's surprising how often you get something from a relative or from a carer or a friend that changes the direction of travel. We put together what we call our preliminary investigative assessment. So at this stage, what we're doing is gathering information. We're bringing it all together, putting it into a format to allow us to discuss it with the full team. And that process can go on, it might be a couple of weeks, or it might go on longer, that we're pulling information. So cases are discussed every week until we accept them. We use the H3 as a sort of a standard cognitive assessment for the service, but beyond that, we're also going to have OT, psychiatric assessment, and neuropsychological assessment, which is, most people don't need me to tell them probably, but you've got a range of testing there which broadens out the kind of information we get on pattern of cognitive deficits, and that we get a better sense of which areas of the brain have been affected, which is another real valuable essential for differential. Next slide, please. So assessment questions, these are not exhaustive, and other questions are available, but this gives you the sense of what we're kind of looking for. Age and gender, the research speculates that onset is third to eighth decade in the female life, fourth to eighth in the male life. We don't set rules on these things, but it's good to have this information. Has there been any damage to organs or physical health, or particularly organs caused by alcohol? One might begin to speculate that there has been damage to the brain as well. What medications? What are you being treated for? BMI, because an initial measure is really helpful to see progress, etc., but also to start getting people to think about unintentional weight loss. If anybody notices that there's some of the paraphrasing of some of the Kane criteria here, you're absolutely right. Any signs of pins and needles, gait and balance problems, possible cerebellar damage? We do look really for a history of poor engagement. That's often, attributed to the fact that people are drinking or they're not motivated. In point of fact, we take the view that alcohol changes the brain and compromises executive functions, slowly but surely. And actually, it gets harder for people to engage. Does the person have a standing mental health diagnosis? Are they in treatment for mental health problems? We want to know as much as we can about cognitive problems, and as going with the Kane criteria, it's not necessarily amnesia we're talking about when with cognitive problems, and that these problems problems in engaging and planning and organising as well. Have there been any concerns about cognition? So these are the kind of questions we would be asking. Basically we're leading in to get the full history, but we're not concluding immediately that alcohol is the main sort of driving concern. Next slide, please. And what I'll do is I'll hand over to Anna now, because she's got the colourful slides with the pictures in them. Over to you, Anna.
Hiya. Yes, I suppose just that ARBD is a bit of an umbrella term, but primarily we are looking often for, thiamine deficiency as primary cause for their memory problems. So there's the Wernicke's encephalopathy that everyone always kind of thinks of. That's a medical emergency, confusion, ataxia, nystagmus, and the need for the intramuscular Pabrinex injections or IV for that. But then I suppose where we tend to become involved is where there's the more ongoing long-term memory problems, kind of thought of maybe a bit old-fashioned now as Korsakoff syndrome, so after the acute syndrome of Wernicke's. And we're often encouraging acute hospitals and things to keep going with Pabrinex injections for a little bit longer than their plan of the 3 days and then stop. As long as there's memory problems there, it's always worth continuing with what could potentially be the treatment to reverse the memory issues. Next slide. So like I said, ARBD, I suppose we kind of think of it as a bit of an umbrella term. So there's a Wernicke-Korsakoff syndrome as a result of acute thiamine deficiency. amnesic disorder due to use of alcohol, and dementia due to use of alcohol that are in the kind of psychiatric classification system, the ICD-10. But really there's quite a lot of factors that can contribute to someone's memory issues. So chronic dehydration as a result of alcohol being directly neurotoxic in the brain, not full-blown acquired brain injury syndrome, but often people with alcohol problems have had a range of minor head injuries as a result of falls and maybe fights and things as well. Small vessel disease kind of associated with diet that's associated with heavy drinking. Hypoxic brain injury, quite common as well from repeated seizures, and then the impact of the repeated seizures itself and repeated detoxes. So whilst we're looking at what's primarily thiamine deficiency, there's a range of factors that contribute to memory problems. Next slide. And basically what we're looking for is people with short-term memory problems, difficulty forming new memories, and then the more frontal lobe damage stuff, so problem solving and abstract thinking difficulties, so like we've got there. So other factors in cognition tend to be fairly well preserved though, like visual spatial functioning and language and things, so it tends to be primarily short-term memory and problem solving issues. Next slide. So when we get a new referral, we do tend to have a wee look through any brain imaging that's there. We wouldn't specifically like rule out ARBD because the scan's normal, and we wouldn't specifically always request a head scan in someone that's not had one. But pretty much everyone we get referred has usually been through having head scans, because often they've had, not just 1 or 2, but 20 or 30 hospital admissions with falls and seizures and things. So I suppose classically you're looking for cerebellar atrophy, frontal lobe atrophy, but actually what we tend to notice most is a comment of global atrophy in advance of age, or sometimes ventricular dilatation. And we would just have a look to see if there's anything else obvious going on in the head scans, like extensive vascular changes rather than just minor small vessel disease, that might be suggestive of more of a vascular dementia picture, or if there's an acquired brain injury evident. Next slide. And then I suppose this was just about a few of the things that we're commonly maybe where there's we're swithering between if it's ARBD or something else. So a lot of our referrals come from acute services, like medical wards and things like that in hospitals, where often it is about identifying what is more of people still having ongoing alcohol withdrawals or infection. So we don't set time frames on when we would assess someone. Like I think dementia services might prefer to wait a bit and see if things resolve, but often we are set up to try and capture people whilst they're in hospital before they're discharged back to the community and back to drinking again in unsafe circumstances. So we try to be as flexible as possible with when we'll assess, and we'll sometimes, maybe after a week or so, if they appear stable and no longer in withdrawals, would go and visit, because it is all about capturing them early and trying to divert them out of the cycles that they're in or out of pathways towards care homes and into kind of trajectories of recovery. But things that might make us think delirium's still ongoing is if there's still evident signs on their bloods or evidence of ongoing treatment for infection, or if they've still got signs of alcohol withdrawal. But also if it's quite a fluctuating presentation and that kind of clouded consciousness, or if there's like delusions and psychosis, like if they're hearing voices and feeling paranoid and things like that, that's not really a feature of ARBD and does make us think maybe it's more something like delirium still going on. New slide. So I suppose the other common kind of trying to pick apart which is substance use versus ARBD. For example, long-term use of benzodiazepines can cause cognitive impairment of itself, withdrawals from alcohol, but also withdrawals from other drugs such as benzos, or if there's an ongoing drug-induced psychosis and that's presenting itself more as memory and problem-solving issues in someone. Sometimes it is a bit about trying to just take a clear history, I suppose, of how long they've been drinking for, and keep coming back to like the factors that Grant said, that basically if they have long-term alcohol use and a range of other factors such as problems with their liver, multiple hospital admissions with alcohol-related causes, peripheral neuropathy. If thiamine started to affect the nerve endings in their hands and feet, the chances are it might have affected their brain as well. So sometimes it's just about looking for evidence that suggests, yeah, they've probably, alcohol has undoubtedly affected their memory, or versus someone that maybe has a bit of a history of alcohol use, which is less convincing, but also quite a lot of street drug use. You know, it might be a bit less clear and you might wonder about other causes. Next slide. So progressive dementia is another one, trying to differentiate between that and ARBD. As Grant's already said, ARBD will not get any worse if the person is abstinent. So if there's any decline despite abstinence, then that's suggestive of more of a progressive picture going on. Also, it's more of a global cognitive impairment, so problems with other functions such as language and visual spatial awareness. Sometimes they've had MRI head scan or SPECT scan, although sometimes alcohol can confuse the picture and the results of that. But if there was very extensive vascular dementia changes, for example, or clear evidence of another process going on, and neuropsychological testing can be really helpful as well. Although all of this, I suppose, is much more easy in abstinence, and in abstinence it's quite easy to tell between dementia and ARBD. Where someone's still drinking, sometimes the picture is a bit more clouded than sometimes it is, just like any other mental illness. About assessing someone's safety if they're at home, continuing to drink and have clear evidence of a cognitive impairment, just in the same way as you would if they had like a schizophrenia or major depression. Despite their drinking, if they're unable to safeguard their needs, you can tell if it's more than just alcohol, really, and if it's, a decline as a result of significant cognitive impairment. And it might be that they need a period of assessment and sobriety, whether that be in hospital, and, things become clearer over time. Next slide. Sorry for racing through that so fast, everyone, but I think that kind of covers most of our main points. So really the main kind of differential diagnosis points that we're looking out for to identify if it's ARBD or something else is if it's a delirium or other substance use or progressive dementia. I didn't mention too much about, but also if there's acquired brain injury there or acute mental illness, sometimes that can confuse the picture a little bit as well. But basically it all comes back to, is this person presenting with memory problems basically as a result of malnutrition, thiamine deficiency and alcohol? And you can tell even that it's easier in abstinence, but even with someone who continues to drink, you can tell by collecting the risk factors if they've been drinking over a long period of time, if there's also evidence of malnutrition, like I say, the impact in the nerve endings in their hands and feet probably also impacted in the brain, repeated hospital admissions as a result of unplanned detoxes. So if you can build up a clear picture like that, then it probably does help us point towards ARBD as a primary cause. And I suppose basically we're also asking ourselves, so what ARBD is, but also will supports with abstinence and cognitive rehabilitation benefit the patient to move forward, which is probably a key, as well as diagnosis, that's probably kind of the key to what support we can offer. And I think that's us. Well, next slide, sorry. Forgot about this a little bit. So I don't know if Grant, you wanted to pop in again here?
Yeah, so it was just to kind of highlight some of the things. These are some of the difficulties that we face. The assessment can be quite complex, but that quite often getting somebody a detox, finding somewhere that somebody's wanting to, the people are seen as bed blockers, etc. We get referrals from all over, but quite often service users are not abstinent, and we don't have the bed space. We don't have any beds ourselves. Acute hospitals, most of our referrals are coming from there. But at the end of the day, they're not the best place to assess. So these are just some of the, although we can do these things, that there is no lead care group, so we don't have the identified resources for assessment. Next slide, please. These are the levels of support that are available in Glasgow. The care homes, the Penumbra service is currently functioning more as almost like a post-detox assessment unit. The weekly care unit is is it more independence there, and it's a higher staff to service user ratio? Actually, if you look at this, we're able to step things, from, the highest level of support right down to somebody moving back through this network and back to their house with supported living hours going into their own tenancy. Next slide, please. And just in case anybody doesn't know, this is Ken Wilson's sort of 5-stage model of rehab. The stages are pretty self-explanatory, but we've rejigged our services now to kind of match this 5-stage model, as I was saying, that, moving through the phases with reducing support right back to coming home at the right time. And it is stage duration is service specific. Next slide, please. And this is what we're trying to do. I borrowed this from Barbara Wilson. Enable people with disabilities to achieve their optimal level of well-being, to reduce the impact of their problems in everyday life, and help them to return to their own most appropriate environments, and basically participating in effectively in valued activities. So if this is where we are coming to, and this is what we are aiming for, we do need to do our homework, we do need to do our assessment, we do need to do our research, we do need to rule out any other potential possible causes or any other possible confounding factors, or we could be asking someone to participate in something that would be a bit too much for them. Next slide, and I think that is the last one. Thank you.
Next we have Elizabeth Brooks and Lawrence Pavia from Healthcare Improvement Scotland, and they're going to be presenting now about visualising alcohol-related brain damage support and how to engage clinicians in improvement. So thank you, Lawrence and Elizabeth.
Thanks, Shanpreet, and thanks for having us along today and the opportunity just to talk a wee bit about some of the support that we were able to offer NHS Tayside following a significant case review of patient 19. So the findings from the significant case review identified that there was potentially undiagnosed ARBD within this person's journey. And some of the aims of that significant case review are around identifying areas of good practice. So it was great to hear from Grant today, because that is one of the areas of good practice that we've been looking at to support some of the improvements that we might want to make. This was really about an opportunity to use the significant case review as an opportunity to learn and improve. And what I would say is that what was really heartening and what was really positive was the engagement from people across NHS Tayside and across the many different disciplines that are involved in someone's care in this kind of aspect, and a real willingness to improve and a real willingness to work together to try and improve the situation. So we were starting from a really good base, and for anybody that's on the call from NHS Tayside, we just want to extend our thanks again for that, because it was a really good piece of work, done quite quickly as well, which was great. And again, I suppose what's the outcome? We want to identify actions required to improve systems and practice, and determine what changes are actually needed. Sorry, one of my screens has just died on me, so classic. So there was a number of recommendations within the significant case review. We were able to focus in on the two that I've highlighted just now, and they were really around procedures for identification and investigation. So as Elizabeth will take you through, when we look at the pathway, one of the key things for us that we identified was, who notices there's a problem, and then what is it we do once we notice there's a problem? What is the pathway? How do we get the right support and at the right time? And then the kind of second recommendation that we've looked at is around guidance training for staff. I think from what we picked up from people, there's maybe a lack of awareness around ARBD, and maybe the starting point for NHS Tayside is about ensuring that people are trained and understand the signs to look out for. But crucially, it's about, what do we do once we've identified? How do we do the assessment, and how do we then manage the treatment of the ARBD? So we were approached by NHS Tayside and to come along and take a bit of a quality improvement lens to how we might improve that pathway within NHS Tayside. It's really around an examination of how the service is set up just now, and then identifying what it is we want to do going forward. And that was supported by that short life working group of all the different professions that I've already spoke about. And it just meant that we had lots of the right people around the table. Next slide, please. So taking that kind of quality improvement service design approach, we've applied the principles of the Scottish approach to service design. And we had really been focused in on that kind of discover and define and develop stage. So you'll see that double diamond there. And Benj will give you a wee idea around what delivery might look like there. So in terms of discover and define, it was really about establishing and mapping the current ARBD pathway. So again, Elizabeth will take us through that, but we didn't have, or I don't think people working within NHS TASAID had a clear view of what that pathway might look like. And you'll see from Elizabeth's slide that it isn't a linear pathway. There's lots of different aspects to that pathway, but it really helped us to get people to be thinking in the right place by having that kind of baseline around here's how it works just now. And then from that, what we were asking people to do is to identify those key improvement points in the system. And once we'd sort of had a look at that, then we were able to work with the people within the Short Life Working Group to identify the changes that are required and probably the more pressing changes. It's such a big piece of work that you're probably not going to be able to fix everything at the one time, but where was the natural place to start? And then what we are doing as Healthcare Improvement Scotland is we'll be helping NHS TASAID plan for tests of change using the quality improvement lens. How can we test different approaches to supporting people who may have ARBD and learning from that to establish our future operating arrangements for that. Next slide, please, Connie. So I'm going to pass you to Elizabeth to talk about this.
Okay, thanks, Lawrence.
Thanks, Elizabeth.
You will not be able to read the text on the diagram, so my apologies about that. But if I can just sort of give you an idea of why I took this approach in mapping the ARBD pathway. There's lots of different ways of mapping services, and given that we had such a great range of people around about the table, both we actually had folks from the police service as well, for example. So there was that range that everyone knows their own system, but very few people will actually know all of the systems. So we could have done a, sort of some kind of absolutely mammoth spider diagram of what's connected to what. But in this case, I don't think that would have been extremely helpful because you couldn't have seen the wood for the trees, as it were. So what I did was break it down into who notices the problem, and those are the green blocks on the left-hand side. What kind of assessments would be put in place? And then on the right-hand side, what treatments are appropriate once the diagnosis has been made. And you might not be able to see it, but there's a sort of dotted line around about a third of the way up the diagram. So everything below the line was crisis and everything above the line was sort of non-crisis situations. And I think this comes back to the previous speaking, Grant's point about quite often folks were seen when they were in a crisis situation and then they had been admitted into hospital. Although one of the things that really came out in the discussion around about this diagram. So what we did was I pulled this diagram together based on a couple of interviews, and then we used it in the workshop, had it on the table, people were given Sharpies and corrected what was on there. So it was very much as an iterative approach. You don't need to get it perfect the first time. Let's just get everybody around the table. And there were some of those moments of, oh, I didn't realise that was there, or I would have added that in and that kind of thing. But the most valuable thing I think that came out of that were the discussions around about, for example, ARBD being that sort of option once all other options are discounted. I think that was one of the really important things that came out of that. And I think, Lawrence, both you and I were privileged to be part of that, to be part of that discussion, and a lot of the in a lot of ways, it was the discussion that happened around about the diagram that was really important, rather than the diagram in itself. It's not an end in itself. What it did, however, highlight were things like these folks tend to be isolated. So the people who might normally have noticed a deterioration wouldn't have noticed because they were isolated. So we had a lot of really rich discussions around about that. And I think probably because I could natter on about this all afternoon, I'm going to hand back to Lawrence because he's going to keep us on schedule.
Thanks, Elizabeth. Next slide, please, Connie. So based on those, I think Elizabeth's right, just to reiterate the point, it was the tool allowed for the discussion, and the discussions were where we got the most valuable information. And that, I think that's something that we'd like to apply in our future work, is that quickness that you can, as long as you've got something in front of people that allows them to think in the right way, then you will get lots of really relevant information. And The other thing to say is that we know that people are super busy. So to take someone out of their clinical schedule for 2 hours on a Friday morning, it's about maximising that value. And we think that taking that approach has really allowed that to happen. So based on those conversations and based on those kind of 3 key areas in the pathway, what did we find? So around who notes there's a problem, what really kept coming back through is this lack of awareness of ARBD. Means it's not picked up as early as it could be. Again, going back to Elizabeth's point, it was almost like ARBD can be the diagnosis of last resort. When everything else has been exhausted, then we might look at ARBD. And actually, when you guys will know better than I, we know that early intervention around nutrition, reduced alcohol intake can have a real positive impact on that person's recovery. Screening and identifying those with possible ARBD while they are in patients and analysing admission data to pick up those in a revolving door. Which services could help pick up people early when nutrition and abstinence could make the most difference? So again, I think there's probably more work to be done on this, but it's that idea around when there's an assessment of capacity done. If potentially that person has been in an inpatient detox for a while, then they may seem as if they have capacity, but actually if you were to observe that person in their home environment, and unfortunately in terms of the patient 19, a lot of issues were identified by like housing support workers, etc., who had noticed a problem in his ability to manage his own, his life in his own home, but actually we didn't have the structures or the processes in place where that was able to be acted upon. So there is real potential for much wider than clinical staff to be noticing a problem, and it's probably then about, well, how can we then take that forward? And then in terms of the assessment, I mean, you guys again all know better than I, but the absence of beds for individuals to stay sober before assessment. There's so much pressure on bed blocking, delayed discharge, but actually what would be really positive for people here is that they were allowed to have that inpatient stay for the correct period of time. And that inconsistency, easy for me to say, of length of time around for sobriety. So there was no kind of standard approach to how long somebody had to be abstinent for before we could do that kind of standard assessment. And then there's a need for consistency and multidisciplinary assessment tools. So what really came through from the wide range of people that we had at these sessions was that pretty much everybody around that table had a role to play and had some input into that person's care. But actually what we were struggling with was to bring that multidisciplinary approach together. And you'll see from some of the improvement ideas that the group have come up with, they're looking to address that, because I think there's a recognition that no one person can make all of the judgment. I think going back to what Grant was saying as well about the availability of information. So I know in the health service, we really come up against data sharing as a real issue around ensuring that we've got the full history of that person. So there's definitely things that we need to think about there. Who are the right people that need access to all of the information to make the best decision possible at that time? And then thinking about treatment, absence of suitable rehabilitation and long-term stay options for younger ARBD patients. So I was interested that question come up earlier on about younger people, and we had heard of maybe a couple of examples where younger people who had been assessed as having ARBD, tried to put them in care homes, but actually, the age group within care homes, maybe the nature of that person's behaviours, etc., wasn't really conducive. And actually, we're probably asking now, well, where do we take people for rehabilitation? It was interesting, again, Grant and Anna's presentation around some of those options that Glasgow have developed, and I think there's a lot in there for other people to learn from around actually identifying where is it we can take people for rehabilitation. And then we linked it back to the Mental Health Welfare Commission report. Very clear that capacity need for guardianship order isn't reviewed sufficiently. So that's another thing that we felt that we would have to look at in terms of improvements. Next slide, please, Connie. I won't go back over this again, but we did have the 2 workshops, and this is the range of input that we got across a whole host of services and sectors. And again, it was one of the best sessions I've ever attended. It was fantastic, and just the range of different views. But everybody trying to work to the same outcome. And I think, just back to that previous slide, how do we help all the different people who are invested in this to come together and make better decisions? Next slide, please, Connie. So following that kind of second workshop, the findings from our kind of develop phase were that people with ARBD can be stigmatised with the perception that they're difficult to help. So within this significant case review, stigma did really kind of rear its head around a potential reason why the person wasn't supported earlier. And that feeling that in some cases the problems are self-inflicted. So I think, you know, like across all of the alcohol, drugs, mental health landscape, we are battling that stigma, but it can have such a detrimental effect on people's care. And then that assessment of incapacity is of crucial importance and can be difficult to assess because the person is either intoxicated or people with ARBD can have preserved verbal abilities, which can cause practitioners to underestimate deficits. And Elizabeth and I are not clinical, but again, listen to the last presentation, you know, that it's such a complicated area. You know, two different clinicians could assess it in two different ways, depending on the presentation, the environment, the circumstances. So it's just really to keep that in mind. And from those problem statements, we identified key themes for development. So access to assessment and standardised assessment, we've rolled into one improvement. And then thinking about this coordinated hub and shared values and principles, so that talks to that multidisciplinary requirement for all of the different clinicians and other support services to be joining up together to think about that person's care. Connie, next slide, please. So what that resulted in is we were able to identify two focus areas for improvement. So development of a virtual hub, and this is really around improving holistic person-centred care through the development of awareness, assessment and coordination. So it just speaks to what I was talking about there, about this multidisciplinary approach and the wide range of views that are required to make probably the most effective decisions around that person's care. And what we were able to do with the team is start to have a wee think about what would that mean for things like workforce, finance, processes, care and clinical governance. So that this was very much the first kind of iteration of that, and as Ben will probably pick up, this work will now be picked up and more of a deep dive into the kind of key areas that need to be looked at.
Do you want me to just, I'm going to go very quickly through
yes,
this
please,
as well,
Elizabeth.
because Jampreet's, she's just
I know,
switched her video on, so I suspect she's
know.
chasing us. She's chasing us. I just wanted to, it looks as if this is just the structure of the slide, but actually the bit on the left-hand side is a tool that we used in the workshop, and the text that's in there is the text that was recorded during the workshop. Now, we find that it's really helpful to have these physical tools. So this is an A0 piece of paper that got put down on the table. People are given Sharpies, and then the helpful thing is that it structures the conversation around about those pillars of workforce, finance, process, governance. Now, you could have different headings there, but I would suggest if you were considering a workshop around about this, just consider forming some kind of tool like this, because it's really helpful in structuring the conversation and just making sure that you've got everything covered. The box at the bottom, by the way, was for what are the next steps. And I think, Connie, we could probably skip over the next slide as well, which is just the same, unless Lawrence was wanting to, and maybe that lands us on the next steps. There you go.
Benj.
Yep, thanks. So yeah, I guess the next steps, we agreed with NHS Tayside that we would reconvene towards the end of August, start of September, to make sure that there was that kind of I guess, so the short life working group was formed through the discovery and the define stage, but it's making sure that that's still the right stakeholders as we think about how we operationalize some of these improvements and identify if there's any missing. So there's a bit there about getting the agreement and buy-in from those stakeholders, but also from the executive sponsors of the work, and exploring what success might look like. So thinking about what it is that we want to achieve from the work, what the aims are, how we might measure that, and then just some sort of facilitation and coaching. I guess there's 2 workshops have been had already. There's maybe scope for a few more workshops and maybe one-to-one coaching calls to think about how to progress the work, particularly around the 2 improvement ideas. And yeah, I see you've responded to the question in the chat, so that's grand, Lawrence, and yeah, you can include me in that meeting as well with Graham Shand, and I think that'll be really helpful in terms of progressing the work. And I guess I just wanted to also take this opportunity to pick out the two key things that stood out to me from the presentation so far, where I was really struck by that bit about getting more involvement from the significant others in people's lives in terms of not just their clinical history, but also, how things have been going for them, what their behaviours are like, any deterioration in their life circumstances, all these things that we know impact on someone that, a health record won't necessarily tell you, but that a significant other, a partner, a carer, a family friend could make you aware of. And then the other thing is that bit about if ARBD is a diagnosis of exclusion or of last resort, then where are the early intervention opportunities before it even gets to an ARBD service? Because these people, if ARBD is ruled out in the end, these are still people that are working with multiple disadvantages, will probably have multiple complex needs, and they tend to arrive in situations of crisis. So what is the crisis response that not only immediately deals with that crisis, but also the kind of follow-up support to make sure that their conditions don't deteriorate, no matter what those conditions are? Because I was struck by that stat about, people tend to have 20 or 30 hospital admissions before they end up at the ARBD service as well. So how do we as a system respond better to do that early intervention prevention, but, catch people upstream instead of when they're in the river? So just wanted to say that.
Okay. Our next session, we have Dr. Rajiv Krishnadas, who works with Esteem Early Intervention Psychosis service in Glasgow, and also works with the Early Intervention team at Healthcare Improvement Scotland. So thank you, Rajiv.
Hi, Chantal, can you hear me? Yeah?
Yes, we can.
Yeah. Thank you. And thanks for inviting me. So I'm gonna just talk a bit about differential diagnosis of vestibular psychosis and substance-induced psychosis, basically. How I go about doing things within Esteem does not necessarily mean that that's the right way of doing things, but I'm hoping that I am doing all the right things. So the next slide, please. So this is going to be my outline of talk. So what is psychosis, first of all? I mean, what I think is psychosis might not be what another person thinks is psychosis, but I think we need to kind of sing from the same hymn sheet. So what is psychosis? What is primary psychosis? What is secondary psychosis? What is substance-induced psychosis? And now, if a person comes in with substance-induced psychosis, is there a risk of that person transitioning on to something like schizophrenia, which is a primary psychotic illness? What's the prevalence of substance use in primary psychotic illness? What are the negative impacts of that? Some theoretical models and treatment. Now, I know within 15 minutes, it's probably impossible to cover all this, but we'll go through as much as we can. So next slide, please. So when I say psychosis, I generally mean a cluster of symptoms, and this is what most people kind of say is psychosis. Positive symptoms, disorganization, negative symptoms, cognitive symptoms, and mood symptoms. They're like broadly categorized into these clusters or subclusters. I would generally go with positive symptoms or reality distortion as the main thing. So for example, delusions, hallucinations, and lack of insight. They are core symptoms of positive symptoms are the core symptoms of psychosis. And especially that's quite important when all the other symptoms, so for example, disorganized thoughts, for example, racing thoughts can be part of a substance-induced intoxication itself. So for example, stimulants or cocaine, they can cause that. Negative symptoms can be part of an amotivational syndrome during, cannabis use or long-term cannabis use. Cognitive symptoms, obviously, during intoxication and withdrawals. Again, mood symptoms, again, very common during acute intoxication and withdrawal. So when looking for psychotic symptoms in substance use context, I would generally look for the proper positive symptoms, delusions, hallucinations, and lack of insight. If people, I'm thinking that most people would know what that is. And psychosis can be because of several things, and we'll go on to that. Next slide, please. So when I say primary psychosis, or what DSM or the ICD-11 basically says primary psychosis is these conditions. So DSM says schizophrenia, schizophreniform disorder, brief psychotic disorder, schizoaffective disorder, delusional disorder, and some other non-specific diagnosis. In ICD-11, it's schizophrenia, ATPD, that's acute and transient psychotic disorder, schizoaffective, delusional disorder, and other primary psychotic disorders. That's what primary psychosis is, where it's predominantly non-affective psychosis. There can be psychosis in affective conditions like bipolar disorder or depression, in severe depression with psychotic symptoms, but they are not called primary psychotic. They are still secondary because they're secondary to a mood, underlying mood condition. Okay, next slide, please. So I don't know, this slide is probably not very clear. Secondary psychosis, mostly what this kind of suggests, or this slide suggests, is that they've mainly looked at medical conditions, secondary to which there can be psychosis. So for example, autoimmune conditions or CNS problems, central nervous system problems, brain problems, seizure disorders, endocrine problems, all of these things, stroke, etc., etc., etc. They also have two categories: toxic or substance-induced disorders, that is mostly in relation to illegal substance uses, and iatrogenic disorders, which are basically where medications given for a particular condition causes some psychotic. So for example, antimalarials or steroids that can lead to psychotic presentations. Next slide, please. That takes me to what exactly is a substance-induced psychotic disorder. Now, very often there's a, in clinical practice, it's difficult to kind of say what exactly is a substance-induced psychotic disorder and what is a primary psychotic disorder. So when a patient presents to the A&E, or when a patient presents to, or when we go up to see somebody within the wards, psychosis very often presents along with quite a lot of substance use. Okay, so it can be part of, so the psychotic presentation can be secondary to the substance use, or it can be just, the person uses substances in the presence of a schizophrenic illness. Very often at initial presentation, it's difficult to differentiate, but the ICD-11 says that these are the essential criteria. Psychotic symptoms that develop during or soon after intoxication or during withdrawal from a substance. The intensity, duration, and the psychotic symptoms should be in excess of psychotic-like disturbances that are because of intoxication and withdrawal. So for example, like I said, a person can have racing thoughts after the person takes cocaine, but that does not necessarily mean that that's a psychotic symptom. We can't say that that's a pressure of speech, and that's therefore it's psychosis. Okay, it needs to be in excess of what would be a usual intoxication or a withdrawal symptom. So similar, like I said, all the motivational syndrome, depersonalization, derealization, that's another thing. Again, if you take hallucinogens, yes, if there's no lack of insight, and if you're expecting to hallucinate in the absence of lack of insight, then I would not necessarily consider it as a substance-induced psychotic disorder as such. It's just the effect of the substance. The symptoms are not better accounted for by any other mental disorder like schizophrenia, and I'll come back to that. Symptoms are not manifestation of any other medical conditions which we described. It shouldn't be secondary to a stroke or some space-occupying lesion in the brain, and it should cause significant distress and significant impairment in socio-occupational functioning. Next slide, please. What additional points to look for are very often people present with multiple substances use, and then it's very difficult to kind of say what exactly is the substance that caused the psychotic presentation. And there you just say substance-induced psychotic disorder due to multiple specified psychoactive substance. So going back to the previous slide, one of the things which they kind of do say there is a suggestion is that almost always it's self-limiting. The substance-induced psychotic disorder is self-limiting. Sometimes, and they generally say it should, the presentation should completely subside within a month. 4 weeks is what they say. Okay. Generally, in actual clinical practice, what we can actually see is people who go for a night out, and from some club or from some pub, they're directly brought into the IPCU. And so Friday night, Saturday night, Sunday night, and Monday morning when I go to see them, they're absolutely fine. So that's the usual presentation of a substance-induced psychotic presentation. So where one specific substance can be identified, it is, it's a specific substance-induced psychotic disorder. Like I said, the symptoms should be the boundary between normality and a psychosis is where the symptoms should be differentiated from the usual intoxication symptoms, and the duration and severity of the symptoms must be in excess of the side effect of these substances. So next slide, please. There are no pathognomonic symptoms unless, so for example, if a person is presenting with a psychotic illness, you can't say that this particular delusion is specific for that, or this particular hallucination is specific for that, or this presentation is kind of classic of this. There will be certain things. So for example, tactile hallucinations are more suggestive of, say, for example, cocaine use, or but in general, tactile hallucinations can be present even in people with a primary psychotic illness. Similarly, visual hallucinations, we often say, okay, that's probably part of withdrawal symptoms or alcohol withdrawal symptoms. Again, visual hallucinations can be present in several conditions. So there's no pathognomonic symptoms that would say this is there can be pointers, by the way. Okay. And like I said, depending on specific substance use, there could be, and also depending on the character of the user, there could be some pointers. Substance use so generally substance use psychosis would never, not never, would almost always happen in people who have used the substances for a long period of time and who have used in excess amounts than usual. Okay, so that's and used in higher amounts over a longer period of time. And usually, like I said, it resolves or improved after sustained cessation of substance use, even without an antipsychotic use. And that's very difficult for us to kind of decide, because very often benzodiazepines, what the treatment strategy would be to kind of start somebody on a benzodiazepine and see what happens. But very often the psychotic symptoms or the agitation is so bad that we end up having to give people antipsychotic medication. And then it's very difficult to kind of differentiate whether this is a primary psychotic illness or should I stop the medication and see whether it will relapse. It's a very difficult decision to make once somebody has started medication. And that's why within team, at least within early intervention psychosis team, we generally say try not to give antipsychotic medications, because then it's very difficult for us to say whether it's a primary psychotic illness or whether it's substance use, because the management of both are quite different. The duration of substance withdrawal can be quite protracted in certain cases. We know people who have started to get psychotic symptoms after a couple of weeks of stopping substances. I don't know if people have seen, especially, although classically people would say cannabis withdrawal doesn't cannabis withdrawal doesn't present with psychosis. I see quite a lot of people who kind of say, I stopped the cannabis like 2 weeks back or 3 weeks back and suddenly started to hear voices. Now, it could be that the person was always using these substances to kind of help with the voices or cope with the voices, but I see this phenomenon very often. We're kind of not sure whether it's because of that, whether it's a protracted withdrawal phenomena or not. Now, very often, substance-induced psychosis related to substance with protracted withdrawal may also last for a longer period of time. Next slide, please. Some more additional points are incidence range from around 7 per 100,000 person years, which means that if you follow up 100,000 people for the general population for a year, around 7 people, which is kind of what we see, I think, in the Northeast where I cover. It also depends on the prevalence of substance use, by the way. So Northeast of Glasgow, I suspect the prevalence of substance use is quite high. So I might see a lot more than that. But on an average in a year, I would see, I think, around that, around 15 people who probably do have substance-induced psychotic illness, although it's very difficult to differentiate, like I said. And up to 25% of the first hospital admissions for a psychosis is generally a substance-induced psychotic disorder. In high-risk population, the prevalence might exceed. It could be up to 40% of the people can have psychotic illness or substance use psychotic illness. And it's very difficult to say how the prevalence rates and the incidence rates and the treatment strategies are very difficult, because almost all conditions, they generally exclude substance use as a treatment. For treatment, all trials kind of exclude substance use. Next slide, please. So substance use psychosis, this is a table. I'm hoping that the slide can be circulated after some time. So a lot of conditions, substance-induced psychosis can present with intoxication, drug withdrawal. This, like I said, cannabis, generally they say no, but I'm not really completely sure about that. Similarly, opiates as well. They say intoxication and withdrawal, it's very rare, psychotic symptoms, but I have seen people who have had that. So there's no one size, or it doesn't fit everybody. Most people don't read this textbook, basically. So next slide, please. Tell me when I have to stop. Chanprit, just throw something at me. So the transition rates into primary psychosis. So this is one of these things where if I present with psychotic symptoms induced by a substance, what is the chance of me transitioning into a primary psychotic illness? Okay, almost 25%. That's what, so 25% of the people would go on to develop a schizophrenic illness, basically, okay? And it can be up to 35% in people who use cannabis. So now then the next question is, should everybody who presents with substance-induced psychosis, should esteem or should early intervention people take on everybody, because there's a likelihood that they will go on to develop psychosis? Actually, there's no evidence to kind of suggest that any intervention would kind of prevent this transition, basically, okay? So I don't think, and service-wise, it would be impossible to kind of take on everybody who has a substance use problems. Next slide, please.
Probably just another couple, 2 minutes or so, Rajiv, if that's okay.
That's fine.
Thank you.
Fine. So pointers towards an independent psychosis would be where the psychotic symptoms precede substance use, persist despite abstinence. Psychotic symptoms manifest even when substances are not used. Manifest psychotic symptoms not in the form or content usually seen in conjunction with particular substances, where there's a personal history of schizophrenia or a family history of schizophrenia. Next slide, please. Again, high prevalence rates among people with psychosis, and therefore it's very crucial that we differentiate these two. I'm not going to go into each figure, but you can see it is quite high, especially cannabis use, 83%, cigarette use, very high, although we rarely see people with cigarette or nicotine-induced psychosis. Next slide, please. I'm not going to go into this. Obviously, there's quite a lot of negative impact of polysubstance or substance use in psychosis. The slides are there. We can go through. Generally, if substance use is associated with psychosis, there is a poor prognosis either way. Next, please. And there are several causal models. You can all go through this again. It's there on the slide. I don't want to kind of take more time. Next slide, please. And one thing this I would kind of say is very often people don't ask, why are you using these substances? Okay, why do you use substances? And it's absolutely crucial to ask this. We always generally kind of say, oh, substance use is bad. Don't use substances, don't use substances. But very rarely we ask, why are you using it? It's absolutely crucial that we make, because the reward effects of these substances can outweigh everything else. Everything, whatever incentive, other incentive that you give, it will fail then. Okay, next slide, please. An integrated treatment is the preferred model. So you treat both psychosis and substance use at the same time. Next slide, please. And three things which I want to kind of say: they're highly disengaging population, people who use substances, and therefore it's absolutely crucial we aim towards that. Long-acting injectables almost always preferred. I prefer that, even if you're not sure if it's substance-induced psychosis. If the person has several psychotic episodes, you still continue long-acting injections to prevent another episode. And clozapine has a special place for this. In the context of disengaging, that's quite complex. To start somebody on clozapine who's not taking it properly. So that we need to keep that in mind. Next slide, please. And that should be it. The last slide. Yeah, EI, like I said, there's not a huge evidence for that. But like I said, generally EI has a good prognosis in psychosis, but most of the trials just exclude substance-induced psychosis. So we don't know what happens to people who have that. But generally, use of substance in the context of primary psychosis is not, the prognosis is not very good. And that should be the end. Next slide.
Should we move on to the general discussion then, and we'll stop the recording now?